Good day, everyone. I want to welcome you all to today's class. The topic assigned to me is management of benign tumors of the head and neck. My name is Onota Iloki. We're going to use this outline: introduction, then brief surgical anatomy, then we'll look at some common benign lesions of the head and neck, then clinical features of some common benign head and neck lesions, then evaluation or approach of the patient with neck swellings, then some surgical management, prognosis, follow-up, and conclusion. As we all know, benign tumors are non-cancerous collections of cells or swellings. They do not spread to distant parts of the body. These tumors tend to grow slowly and have distinct borders. They are well defined. Classically, they present as either symptomatic or asymptomatic masses or swellings around the head and neck region. The cause is unknown, but may be linked to environmental toxins and some other factors, or even viral infections. Now, the head and neck region includes the upper aerodigestive tract, where you have your oral cavity, your paranasal sinuses, the pharynx, larynx, cervical, esophagus, thyroid, associated lymph nodes, and soft tissues and bone. Not only that, you have the skull, the scalp, and even some lesions in the brain could be benign. We're only going to focus on head and neck tumors, benign tumors that are actually in our jurisdiction as ENT surgeons. Now let's look at this brief surgical anatomy of the head and neck, showing more of the paranasal sinuses. You can see the sphenoid, the frontal sinus, the skull and the brain is actually not captured in this anatomy. You can see the nasal cavity, oral cavity, the tongue, the nasopharynx. You can see the larynx and the other structures, esophagus. Now, benign lesions or tumors can be found in any of all these sites, anatomical sites. In the sinuses, in the nasal cavity, oral cavity, tongue, larynx, and the neck. In fact, a lot of neck swellings. As we progress, we'll look at so many differentials. Now, the anatomical regions of the neck, you can see the stellocleidomastoid muscle divides the neck into anterior and posterior triangles. And even the anterior triangle is further divided into sub-triangles. But we will not focus on that now. Then not only that, we also have lymph nodes that are distributed all over the neck according to regions. Now look at the lymph nodes. You can see those pre-auricular, you can see the posterior auricular, the occipital, then upper cervical, middle, and lower, then the posterior cervical, submandibular, you know, the deep cervical, you have them all distributed, as you can see, along the border of the sternocleidomastoid muscle. Now, the beauty of all this is that some particular sites that are drained by these lymph nodes, the lymph nodes drains the lymphatic system drains into these lymph nodes will give you an idea of where there's any either infective condition or any likely tumor. But this, again, benign tumors are not malignant. So affectation of lymph nodes may not be the case when you're dealing with benign lesions, unless if they are effective diseases or inflammatory conditions. Now, let's look at some differential diagnosis of a mass in the head and neck. Now, the differential diagnosis of a mass in the head and neck is broad. Accurate diagnosis, especially of a neck mass, is critical. It is helpful to consider the differential diagnosis in three broad categories: congenital, inflammatory, which can also be effective, neoplastic. Under neoplastic, we are talking of benign, not, although there could be malignant lesions, but we are focusing on benign tumors or benign lesions. Now, the patient's history and physical examination will often allow designation of the neck mass into one of the above-mentioned categories. For example, if it's a child that a swelling is found either in the neck or around the head, it could be congenital or developmental. Then if it's an adult, for instance, above 40 years of age, it could be more sinister and point out to something more dangerous. So from the history and the examination, one will be able to categorize the neck mass or the head and neck tumors into various categories, like as I've said earlier. Is it congenital? Is it effective? Or neoplastic? However, particularly in adult patients, the potential for malignancy in any neck mass should be adequately excluded before a benign diagnosis is established. Very important, take notes. Now, types of benign tumors of the head and neck. Now, we're going to look at another classification based on the tissue that is involved. Adenoma is a benign tumor that occurs in a gland. A chondroma forms in a cartilage. Fibroma forms in the fibrous tissue. Hemangioma forms in blood vessels, while lipoma forms in fatty tissues. Lymphangioma develop in lymphatic system. Meningioma begins in the meninges, which is a tissue around the brain. Myoma develop in smooth muscles. Neuroma develops within nerves, and osteoma develops from bones. So these are some terminology that we need to familiarize ourselves with. Now, what are these common benign masses of the head and neck? We're going to focus more on the neck because that's our jurisdiction compared to the brain or the skull. Branchial cleft cysts, pteroglossal duct cysts, cerebropontine angle tumor that happens in the brain, that's our territory. Glomus tumor, can find them in the middle ear. Now, other common benign masses include carotid body tumors, glomus jugulare. Now, in the sinuses, in the nose and paranasal sinuses, talk about inverted papilloma. You can also have simple nasal polyps. You have benign salivary gland tumors like pleomorphic adenomas can be found around the parotids, even the other salivary glands. Hemangiomas, dermoid cysts, epidermoid cysts. Now let's look at the branchial cleft cysts. Now, branchial cleft cysts are embryologic anomalies and are defined by the internal opening of the branchial sinuses arising from incomplete obliteration in embryogenesis. Now, they may present as fistula, cysts, sinus tracts, or cartilaginous remnants, and clinically encountered on the anterior neck and upper chests. Now, the branchial cleft cysts account for almost 20% of pediatric neck masses. They usually present in late childhood or early adulthood. The cysts are relatively consistent in their location in the neck, anterior to the sternocleidomastoid muscle. Now, the bronchial cleft cysts are further subdivided based on the developmental origin. For example, we have the first bronchial cleft cyst, which accounts for less than 1% of bronchial cleft anomalies. It has type 1 and type 2. They typically appear on the face near the auricle. Now, the first bronchial cleft cysts are further divided, like as I said, type 1 and type 2. You'll see the picture I will show subsequently. Now, type 1, first bronchial cleft cysts are duplication anomalies of the external auditory canal and are of ectodermal origin. They pass through the parotid gland, often in close proximity to the facial nerve. Now, let's look at this beautiful illustration. You can see the first bronchial cleft, type 1, around the auricle, and the type 2 just below the angle of the mandible. Now, why the second bronchial cleft cyst and the third and fourth caused along the anterior border of the sternocleidomastoid. The first one in the upper part of it is the second bronchial cleft cyst, now followed by the third. Then the fourth is lower. You can see the relationship with the great vessels and the nerves. Now, the second type 2 first bronchial cleft cysts, the type 2 bronchial cleft cysts are more common and typically present below the angle of the mandible. Now, they contain both ectoderm and mesoderm and pass through the parotid gland, medial or lateral to the facial nerve, and end either inferior to the external auditory canal or at the bony cartilaginous junction of the external auditory canal. Now, the second bronchial clefts are the most common type of bronchial cleft anomaly. They are usually located just inferior to the angle of the mandible and anterior to the sternocleidomastoid muscle in the corresponding level 2 region of lymph nodes. Now, the sinus tract of a second bronchial cleft cyst will travel through the deep structures of the neck and opens into the ipsilateral tonsillar fossa. Now, let's look at this picture. This is a picture illustrating second bronchial cleft cysts. They present with anterior neck swelling or more laterally, as you can see. Now, the third bronchial cleft cysts also are located anterior to the sternocleidomastoid muscle, but are typically lower in the neck than the second one. I've mentioned that earlier. Now, these anomalies end in the pharynx at the hyoid membrane or piriform sinus. While the fourth cleft cyst, bronchial cleft cyst anomalies, they have a laryngotracheal sinus tract that begin at the apex of the piriform sinus and extend inferiorly to exit the pharynx through the lateral cricothyroid membrane. Recurrent infections of bronchial cysts can occur and a fistula tract to the skin may develop. Recurrent infections may complicate surgical removal, increasing the risk of injury to important structures such as the facial nerve when the parotid is involved. Now, another very common benign lesions we should not forget to discuss is pterygossal duct cysts. Pterygossal duct cysts are the most common form of congenital cyst in the neck. However, carcinoma has been diagnosed in approximately 1 or 2%, but is very rare. Patients with pterygossal duct cysts often have ectopic thyroid glands, which are defined as functioning thyroid tissue found anywhere other than the usual anatomical location of the thyroid gland. Now, I must emphasize that seeing an anterior neck swelling, you must actually be thorough in making your diagnosis because the differentials are numerous. It could be an ectopic thyroid, it could be a simple goiter, and can even be just any other cyst or a lipoma. Now, pteroglossal duct cysts present as a midline mass in the arterial neck. They are often asymptomatic until they become infected in the setting of an upper respiratory tract infection. Pteroglossal duct cysts are usually diagnosed in childhood, but up to 40% may present after the age of 20. Look at this illustration, pteroglossal duct. You can see it there, the location. Now, the clinical manifestations of pteroglossal duct cysts. Patients with pteroglossal duct cysts usually present with a mobile, soft, painless midline upper neck mass that appears to be cystic. Now, in most cases, the cyst is at or just below the hyoid bone, adjacent to the thyroid membrane. Pteroglossal duct cysts may occur anywhere along the pteroglossal duct tract, from the foramen cecum at the base of the tongue to the level of the suprasternal notch. You have to remember your embryology. Pteroglossal duct cysts should be suspected in those who present with a cystic mass in the midline of the upper neck. The swelling usually moves with the protrusion of the tongue. Take note of that. Diagnosis is confirmed by imaging studies, fine needle aspiration, cytology, and surgical pathology when the histology is out. Now, ectopic thyroid tissue can be confused with pteroglossal duct cysts. So in most cases, clinicians, you have to do ultrasound. You have to confirm the thyroid is there in the neck. And apart from that, sometimes it could be mistaken. An ectopic thyroid can be mistaken to be a pteroglossal cyst, and when you remove it, you will now render your patient without thyroid gland, and you know the implication of that. So if ectopic thyroid tissue is suspected on CT or MRI or ultrasound, then obtain radionuclide imaging scan to locate all additional functioning thyroid tissues. Now, what I'm trying to say here is that you must establish that there's a normal thyroid function gland that the patient is having, so that you don't end up removing the only functioning thyroid glands. Now, still on differential diagnosis of pteroglossal duct cysts, most of them are the midline neck masses. You have your dermoid cysts. Dermoid cysts are due to entrapment of epithelium in deeper tissue occurring either developmentally or post-trauma. Dermoid and sebaceous cysts tend to be quite superficial and less tethered to the underlying structures, including the hyoid bone as compared with pteroglossal duct cysts. In that case, they will not move either with swallowing or protrusion of the tongue. Now, brachial cleft cysts. Brachial cleft cysts can be confused with pteroglossal duct cysts if they are somewhat medially located. Now, if brachial cleft cyst is more medially located, it can also create some confusion. Brachial cleft cysts are often associated with a sinus tract or fistula, whereas pteroglossal ducts may not. Now, lipoma and other differentials, they are quite superficial and have ill-defined edges. In lipomas, you have your sleeping sign. As clinicians, you know what to do. Other causes of midline neck masses include the following: thyroid nodules, hypertrophic pyramidal lobes of the thyroid, the midline lymphadenopathy. Just to mention but a few. Now, medially located salivary gland tumors, sebaceous cysts, laryngocele, lymphatic malformation, in fact, even deep neck space abscess. Now, another benign lesion we should not forget to mention is parangangliomas. Parangangliomas of the carotid body, previously called chemodectomas, and jugulo-tympanic paraganglia, previously called glomus jugulare and glomus tympanico. They are highly vascular tumors, typically benign tumors that can present as a neck mass. Parangangliomas are neoplasms that arise from extra adrenal chromaffin cells of the sympathetic and parasympathetic paraganglia in the neck. Within the head and neck, among the parangangliomas, the carotid body tumors are the most common, followed by jugulo-tympanic glomus tumors. Now, the carotid body tumors are often pulsatile, and a brew can be heard on auscultation. Classically, they are described as being mobile in a side-to-side direction, but not in a vertical direction, the so-called positive Fontaine's sign. Approximately 1/3 are inherited as part of genetic syndrome, and genetic screening is advised for all patients because of the implications for malignant behavior and multifocality. Now, let's talk about inverted papilloma. This one occurs in the nose and sinuses. Inverted papilloma is benign, and I'm mentioning this because it has this aggressive behavior, and not only that, it can actually transform to malignancy. Some percentage, few percentage, let's say 5% can actually be malignant. Now, inverted papilloma is a benign, locally aggressive neoplasm that is associated with squamous cell carcinoma in approximately 5% of cases. Now, treatment for inverted papilloma is primarily surgical resection, which is increasingly accomplished using endoscopic approach. Radiotherapy is added if it is associated with squamous cell carcinoma or if it is incompletely resected. However, local recurrence is common with inverted papilloma. Then, apart from having papilloma in the nose and sinuses, can also have respiratory papillomatosis in the larynx. Okay, you can also have papillomas even in the oral cavity and other parts of you have papilloma in other parts of the body. You can even have it on the skin. Okay. Now, for inverted papilloma, these are synonyms, other names you can call it, but we still maintain our name. Now, this is a CT scan, a coronal view showing some hypo, I think isodense lesions occupying the nasal cavity. Actually, you can see the nasal septum has been destroyed. And the same lesion, you can see the left maxillary antrum completely filled compared to the right. You can see what's happening here. This could be mistaken for malignant sinonasal tumor. But this patient actually is a case of inverted papilloma. It could be very destructive. Now, how do we approach a patient that has a benign neck mass or a benign neck lesion? Evaluating a neck mass relies upon findings on the initial history. So history is very important. Now, you take your history. When did the patient first experience the symptom? What's the symptom? That is a presenting complaint and its associations. Then you want to know the progression of the swelling and all that. You know how to plaque such a patient. Then you look at comorbidities of the patient. Also look at family and social history and treatment history and all that. Now, then physical examination, you have during physical examination, you'll be able to triage the neck masses, like as I mentioned before, into the various categories and direct further evaluation with laboratory testing, imaging studies, and tissue biopsies. I want to say that on no account should an ENT surgeon or even any physician biopsy a neck mass without looking for the primaries, or maybe there is a swelling in the neck and it's a lymph node or any other mass. A complete head and neck examination should be done. The nasopharynx should be looked at, the oropharynx, the larynx, because just taking a biopsy, telling you this lesion, for instance, is mitotic, for instance, that's not the primaries. Then if it's a benign lesion, great, but you must know exactly what you are dealing with so that the treatment can be appropriate. Infectious etiologies of a neck mass are suspected based on the history of the mass developing within a few days or weeks. And your patient has a recent upper respiratory tract infection, or there's dental infection, there's trauma, travel, or exposure to certain animals, you'll be thinking more of an infective cause. Now, physical findings may include there's going to be warmth, differential warmth, the skin changes, tenderness on palpation, patient might have history of fever, then other systemic signs of infection, then maybe patient has rhinorrhea and all that, you know. Now, most neck masses in adults, like as I said, majority, once you're 40 years and above, is suspicious. Okay. Now, patients who do not have signs or symptoms suggestive of an infectious etiology should undergo a complete workup or further workup. Now, in terms of diagnosis, patients with a neck mass that is not infectious, you have an increased risk for malignancy for such a patient, require further testing to elucidate the etiology of the mass. These ancillary tests may include laboratory tests. For instance, you want to do Barra studies, a few selected imaging studies, neck ultrasound. You want to do CT scan with contrast of the mass. You want to do EL-ROi or do other serological tests. Now, after completion of ancillary tests, patients diagnosed with a specific condition should be treated accordingly. Those without a specific diagnosis should be followed clinically until the neck mass has resolved or a diagnosis can be established. Now, let's go back to patient history. A thorough patient history will often narrow the differential diagnosis of a neck mass. Age, like as I said, the age of the patient is critical in indicating the type of workup you will do. If it's a child, for instance, a 2-year-old child with a neck swelling, and you will be thinking more of congenital lesions. It could be a hemangioma, depends on what you see, on the physical examination. Then if the patient is less than 16 years, majority of pediatric neck masses are either inflammatory or congenital in origin. Okay, but like as I said, the younger the child, the more you think of congenital or origin. Then acquired can developmental as the child grows. Such symptoms can start manifesting. 16 to 40 inflammatory congenital etiologies also account for the majority of neck masses, but above 40 suspect malignancy. A neck mass in anybody above 40 in adult, like as I said, should be considered neoplastic and potentially malignant until proven otherwise. The probability of a malignant neck mass is further increased in the setting of tobacco or alcohol abuse or use. Now, what is the growth pattern? Characteristics of the mass, such as its duration, growth pattern, absence, or presence of pain, are critical in making diagnosis. Now, other history that is important, a review of systems should include the presence of fever, night sweat, weight loss. This constellation of symptoms is suspicious for lymphoma, whereas high spiking fever suggests acute infection. Now, family and social history, I wrote it very bold, very important. Then occupational history is important. Now, back to physical examination. The physical examination should include a careful evaluation of all anatomical areas that may be relevant to the neck mass, although the focus will initially be on the head and neck. A complete examination can indicate signs of systemic illness, including infections, inflammatory conditions, and malignancy. Now, back to the neck, you can see the various areas where all these lesions can actually occur. You can have deep neck space infection. You can have other infections around the head and neck. For instance, you can have preauricular swelling. You can have postauricular swelling. You can even have swelling around the posterior triangle, and even supraclavicular swellings. Okay, so parapharyngeal space swellings and all that. So whenever you see such swellings, you must take your full detailed history, physical examination, and work up the patient, do your radiological investigations, and make your diagnosis. Treatment, definitely, if it is effective, give anti-infective antibiotics. If it is benign lesion like a diagnosal cyst, complete excision. If it's a bronchial cleft cyst, complete excision. Then if it's there's an abscess, you drain, and thereafter you deal. Now, examination of the mass, you have to do localization of the mass. Where is it sited, the size, all the features of the mass. Is it firm? Is it soft? Is it, tender? You check the surrounding skin. Is it attached to the underlying structures and all that? Is it ulcerated? Then you palpate the one that gives you, a heave, or you listen if it has a brew and all that. Definitely you know what you're dealing with. Preauricular and angle of the jaw, when you see lesions, they likely represents either salivary lymph node tissues in the parotid, or it could even be a preauricular abscess, cyst or abscess and all that. Now, in the central neck, most commonly represent tissues that's like, thyroid, hypoglossal duct cyst. Then this could also represent a dermal cyst. So now, pointers to malignancy. If it's a lymph node above 1.5 centimeter, is it firm, in texture? Is it fixed or reduced mobility? Is the skin, overlying skin ulcerated? Suspicious. Characteristics of the mass. Palpation of the neck mass is critical, with attention to its location, size, shape, consistency, tenderness, mobility, and color. Now, neck masses due to reactive lymph nodes are usually discrete, mobile, firm, or rubbery, but not rock hard and slightly tender. Now, rock hard fixed masses raise concern for malignancy. Lymph nodes representing metastatic disease may be matted to the underlying structures and are usually non-tender. Now, infected lymph nodes are usually isolated, asymmetric, tender, warm, and erythematous. They may be fluctuant. Now, a firm lateral neck mass that moves from side to side, but not up and down, indicates involvement with the carotid sheath, such as carotid body tumor of schwannomas. I've mentioned that before. Now, a pulsatile quality or brew suggests a vascular lesion. An immobile midline neck mass that elevates with swallowing indicates a thyroid source, such as a thyroglossal duct cyst. However, a thyroglossal duct cyst will move the protrusion of the tongue, whereas the goiter or the thyroid mass would not. Some laboratory studies are essential. Then it depends on what you are dealing with. Most patients should have your complete blood count with differentials. Definitely, if it's an effective cause, you'll see your WBC elevated, neutrophils. The following may be indicated for some patients: a ESRO, though not specific, CRP to evaluate for systemic inflammation or infection. Blood culture, patients are febrile, viral studies, HIV, Epstein-Barr, HPV and co. Specific serological tests can be ordered when there is an increased index of suspicion for disease based on exposure, history, and your physical examination findings. Well, tuberculin skin tests, you can have TB adenitis and all that. Imaging studies, you cannot do without that. Start with basic ultrasound. You don't have your CT. If you're dealing with an abscess with contrast, MRI with contrast, PET, that one you're doing malignancy workup, and in benign lesions, you're not expected to do PET scan. Contrast CT should be the initial study of choice for most adult patients with a neck mass, though that's more for malignancies, but also effective causes. Now, this is a CT scan of a patient that has second bronchial cleft cysts. You can see the hypodense lesion. Well, I think this should be with contrast with ring enhancement, well circumscribed lesion there. Now, fine needle aspiration is the preferred diagnostic approach for most neck masses and typically performed with your 25 to 27 gauge needle on a 20 ml syringe. Now, the nature of the aspirate may suggest particular etiology. If it is bloody, it's dealing with vascular lesions and all that. Serous dark fluids, thick viscous fluids, co-sealed and all that. Now, core biopsy, if the information provided by the FNAC does not establish the diagnosis, core biopsy can be considered, but not in all cases, okay? Most times, if we know it's benign, it's a complete excision, that is preferable. But FNAC gives you an idea of what you're dealing with. 1 to 5 passes are typically performed with an automatic needle gun for precise tissue acquisition. Now, excisional or incisional biopsy. Incisional biopsy is neither here nor there. We don't think that is advisable. But excisional biopsy, yes, complete excision. You do open surgical biopsies in general. Open surgical biopsies in general are discouraged since they can adversely affect the success of subsequent definitive treatment in malignant pathologies and in certain situations. Now, but for benign disease, if you are sure you are dealing with a benign disease, complete excision is okay. But once it is malignant, you do open biopsy, it is disastrous. However, like as I mentioned before, you must look for the primaries where the primary is, especially when you are dealing with the head and neck. Open biopsy of paragangliomas of the head and neck can result in life-threatening hemorrhage. Open biopsy of schwannomas, including those arising from the vagal or facial nerves, may result in permanent and unexpected nerve deficits. Now, periparotid masses may represent salivary gland neoplasms, and open biopsy may increase the risk of tumor recurrence. Open biopsy is acceptable in the setting of an FNAC or core biopsy being positive for lymphoma. Yeah, that's one exception because they need the complete lymph node for actual categorization of the type of lymphoma. Now, when it comes to surgical management, this depends on the diagnosis and the procedure varies, okay? For instance, cyst-trunk operation. This is the standard operation you do when you are dealing with thyroglossal duct cyst. It's the resection of the cyst and the mid portion of the hyoid bone in continuity and resection of a core of tissue from the hyoid upward to the foramen siccum. This procedure was described by cyst-trunk for thyroglossal duct cyst. And for brachial cleft cyst, you have to remove the cyst or the tract up to the bilateral tonsils. In fact, there is a classical incision we describe as the stepladder incision so that you'll be able to get the tract in continuity and excise it completely. Now, this is an illustration of your thyroglossal duct cyst. You can see it there. See the tract and up to the foramen siccum. The hyoid bone, the mid portion of it is removed. Now, I want to say that before I conclude or follow up, the cerebropontine angle tumor that can be found in the brain has its classical presentation, is benign, and surgical removal can be done. Then also the use of gamma knife. Then you can also have middle ear tumors like the vascular tumors. They can also be removed. There are various approaches which can be used to remove them. Going into the various techniques and method of dealing with all these lesions is beyond the scope of this lecture. So you should take note of that. Then also in the nose and parental sinuses, you have simple nasal polyps, which can remove with endoscopic sinus procedure. You have other benign lesions like fibroma, osteoma, and in fact, you can also have cartilage involvement, chondromas, and all that. Any tissue can actually develop benign lesions. Okay, then when you now come to the neck, you have your various neck masses, like as we've mentioned. Then when you come to the oral cavity, you have your ranular cyst, then even benign salivary gland tumors and all that. Even in the palate, you can have osteoma. Then when you come to the larynx, you have your laryngocele, you have your the pharynx, esophagus, you have the pharyngeal pouch, you have your esophageal diverticulums, happening in the esophageal wall. Then you also have your retropharyngeal abscess. These are abscesses. You have your deep neck space abscesses and all that. So it's actually a very big topic. So I want to say that benign tumors can reoccur, especially those ones that are not properly managed. Those that have potential to transfer to malignancy, you must follow up and look out for that. Now, benign neoplasms that are small, circumscribed, and solitary can be managed with simple excision, complete excision. However, if they occur in the face or neck, careful placement of incisions, atraumatic handling of tissues, and meticulous skin and soft tissue closure must be observed to ensure good cosmetic results. Then follow-up of patients, like as I said, is necessary for better outcomes. These are some references you can look at. I want to say thank you. I hope I've not bored you because the topic is broad and I just try to have an overview of it. Thank you and God bless. I think it's time for question and I'll open the floor. The floor is open. You take it from there. I appreciate all of you. Thank you and God bless. Yeah.